My name is Salvatore Parascandola, and I'll be presenting on surgical resection of T4 colon cancers. I have nothing to disclose. Historically, T4 tumors of the colon have been a contraindication to minimally invasive resection. In the COST trial, which concluded that a laparoscopic approach is an acceptable alternative to open surgery for colon cancer, only 12 patients, or 3%, included in the laparoscopic cohort had T4 tumors. Currently, few well-powered data regarding the suitability of a minimally invasive approach to T4 cancers exists. Therefore, the purpose of our study was to conduct a national cancer database analysis to compare the outcomes after curative treatment of pathologic T4 colon cancer between robotic, laparoscopic, and open approaches. This was a retrospective cohort study using clinical data from the National Cancer Database from 2010 to 2016. The NCDB was reviewed for patients diagnosed with pathologic T4 stage 2 or 3 adenocarcinoma of the colon who underwent partial or total colectomy. Kaplan-Meier estimation and Cox proportional hazards regression were used to analyze the primary outcome of survival. (26,260 cases met inclusion criteria. Propensity score matching was then performed. Propensity score matching identified 876 cases per treatment approach and provided adequate discrimination between treatment cohorts. Potential confounding covariates did not significantly differ between all cohorts. No statistically significant differences in any demographic or clinical pathologic variable was seen after propensity score matching. The median age for the robotic, laparoscopic, and open cohorts was 67.4, 67.7, and 67.7 years, respectively. The most common tumor location for all groups was the sigmoid colon and the cecum. 37% of all patients were stage 2, and 63% of all patients were stage 3. Nodal disease was discovered in 63% of patients. The 5-year overall survival for open, laparoscopic, and robotic approaches are seen here. Cox proportional hazards regression showed that both robotic and laparoscopic approaches were significantly associated with decreased mortality hazards relative to open. No significant difference was seen between robotic and laparoscopic approaches. Regarding secondary outcomes, the robotic approach was significantly associated with decreased odds of conversion to open relative to laparoscopic. In those who received adjuvant chemotherapy, a laparoscopic approach was significantly associated with a shorter time from surgery to chemotherapy relative to an open approach. Likewise, a robotic approach was also significantly associated with a shorter time from surgery to chemotherapy relative to an open approach. No difference was detected between robotic and laparoscopic approaches. Regarding outcomes by treatment approach, relative to open, a robotic approach was significantly associated with decreased odds of 30 and 90-day mortality. Relative to open, a laparoscopic approach was significantly associated with decreased odds of positive margins, 30-day and 90-day mortality. No significant difference was detected between robotic and laparoscopic approaches for positive margins, 30-day unplanned readmission, 30-day mortality, or 90-day mortality. Numerous limitations existed in this study. As is common in retrospective reviews, there was a lack of randomization of patients into each surgical approach, potentially introducing surgeon bias. Additionally, numerous variables are absent from NCDB that would have strengthened this analysis. Notably, while we report 5-year overall survival, recurrence rates and disease-free survival are absent from NCDB. Additionally, no variables regarding morbidity rates, and specific complications are available. Furthermore, surgeon-specific data, such as whether or not surgeons were fellowship trained and how many years they've been in practice, are absent. In conclusion, our analysis demonstrated numerous improved short and long-term oncologic outcomes in patients who undergo a minimally invasive resection for T4 cancer compared to an open approach, suggesting the suitability of MIS for resection of these tumors. Additionally, there was a significant reduction in conversion to laparotomy in those who underwent robotics versus laparoscopy. And finally, there was equivalent oncologic outcomes seen between robotic and laparoscopic approaches to T4 resection. Thank you.